make sure that the doctor's order is correct. That it needs to be extubated. We want to check his vital signs, right? Make sure that he actually is able to. No high blood pressure. His breathing rate is less than 30, right? We also want to make sure that he has his weaning parameters. Okay. Which could be a negative 20 on the nip, tidal volume. 5 cc's per kilogram
of ideal body weight.
Just drop that right there.
Is it 5 or 15 for the
15.
VC?
Tidal volume.
Wait, is he going to do it?
Tidal volume. Call it tidal volume.
Should I record this?
Five Gs per
Vital capacity would be 15
Okay.
15 per kilogram.
Yeah. Okay. RSBI of
Less than 100.
Okay. Good. All right.
And then we want to explain to the patient exactly what we're going to do. Okay. We're going to extubate you. We're going to want to go ahead and use the yonkers before we extubate him to make sure that he has no secretions up on top.
Now, Mr. Yanami says use the yonkers above. Now, there's a couple of things that can happen based upon your clinical situation. Okay, you can use the yonkers, but you're not going to get too far down without initiating that real bad gag reflex with this thing. If they don't have an ET tube cuff that has a supraglottic suction port, okay, then you're going to want to. I would take a suction catheter after sitting the patient up. Take a suction catheter and go down and try and get as much up above the cuff with the suction catheter, because I can get further down and more towards the cuff with the suction catheter than I can with the yonkers. Okay, once I've suctioned above, then I'll go ahead and I'm going to pre-oxygenate, push the 100% O2 button on my ventilator. Okay, I'm going to stick the. I'm going to make sure I remove this. I'm going to hold on to this, have my, where's my syringe? It's on here. Okay, I've got my syringe on here. Okay, I'm going to cut the tape. I'm going to hold on to the ET tube so I make sure that it's secure until I'm ready to take it out. Okay, I'm in control of the tube. Okay, so I'll section my patient. Okay. All right, I'll suction again, or I'll stick it down. The patient's shaking, moving, jerking. I'll deflate the cuff, okay? Suction, and as I'm suctioning, I'm going to pull the tube out. Of course, this is hooked up, so yeah, go ahead and pull it. Okay. Okay. Tell them cough, cough, cough. This has got the other. It's cough, 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 cough. You tell them to cough as you're pulling it out. You're leaving the catheter down in there so that the tip is beyond the tube. And if anything does slip past the cuff, you're going to pick it up with the suction catheter. So you're applying suction as you're pulling the whole thing out as a unit like this.
How easy does it come out?
It comes out pretty easy.
Yeah, it's gonna slide right out. Okay, and then you're going to suction the patient's oral cavity again, because if they did cough anything up, you don't want them to suck it back down. Suck it out, and then apply oxygen to your patient. Okay, and check their vitals.
And you want to
make sure that you have supplemental oxygen that is meeting or exceeding what ventilator.
Correct. Like if he's on 40%, you know, you're going to have high flow system. You can put him on a 40% venti mask, 40% cool aerosol. If you have a choice between a cool and heated aerosol after extubation, what would you prefer?
Cool.
Okay, cool.
And you should have racemic available just in case.
Absolutely.
For swelling.
Absolutely.
Instruct on OIS.
Now, is the racemic epinephrine when you suggest it? You only do it if you're going to hear Mark Strider.
If you hear a lot of Strider, then yeah, you can suggest it.
Would you suggest it either way? I mean, after they've had the tube and they...
Not necessarily. Not if it's not. There's no real clinical indication for it. You don't need to give it because then.
Strider, you just hear. Strider, you can hear pretty much once you get the tube up.
Yeah, you'll be able to auscultate it. If you listen to the neck, you'll hear it if there is.
Yeah.
But like Unami says, when you want it, when you need it, you don't have it. That's the time that you need it. You know?
Yeah.
I just want to make an addition that in the NVRC exam, Mark Strider, the difference is Mark Strider is not as much of a noise as the constriction of the airway that makes you gasp for air, which means if you well, I don't want to use gasp, that makes you work, that's the word, work hard to get the air in.
So
Strider would be, right? This is Strider. That's stridor. But if I go like this, and you can see me struggling, that's the difference between marked stridor and a regular stridor. Okay, this is NVRC. And then the difference is which
hits the spinal column, okay? That's marked stridor.
What was that again?
When the sternum touches the spinal column, that's marked
that's
stridor.
what you can see diaphragmatic breathing in some patients, right? Some babies. This really sinks in. And when you say marked stridor, here's another way of looking at it. As you become stridors, what are you seeing? Accessory muscle signs. Actually, this is a better one. Signs of increase in worker breathing, which means accessory muscle use, sternal retraction, intercostal retractions, clavicular retractions. Okay? Who told you you can videotape me?
This is your
My
second
best side.
This is your second starring role.
Okay? So, is that clear? That's the difference between marked stridor. So the marked stridor, what do? You do something that is more aggressive, which is racemic epi. The other one is cool aerosol. And NBRC will always give you scenarios that would tell which is which. Regular stridor compared to marked stridor. Now, the other thing that I want to make sure that you guys are aware of is that we will never extubate the patient laying down. I'd like them to be sitting as much as I can so that when they cough and they end up vomiting, for example, because you know how you, you know how you cough and cough and cough and pretty soon you end up vomiting, stipulating a gag? Well, if the patient does that while laying back, plus the tube gets passed by and stimulates a gag reflex, they might vomit, so you want them upright so that they vomit this way. You wanted them exorcist type. Projectile vomiting that way.
Mr. Yanami.
Okay.
Even if the family signed a DNR, like we extubated a patient, they did a DNR, we extubated, she was completely flatline or laying flat.
She was completely flatline?
No, she was completely flat, laying flat.
Okay, was the relatives in there?
No, when we did it, no.
And now, here's two scenarios. The relative was there, you extubated, patient starts to vomit. What are you going to do?
Turn her head and suction.
Turn her head and suction. Could you have avoided that?
Yes, we could have.
What would the relatives do? Panic,
my
right?
God.
Oh my God, what did you just do? Now they're vomiting. So that's one. That's why I always set them
That
up.
wasn't done.
Two, if they die and they're not there because of the vomiting, what are you going to say? Mr. and Mrs.
You
We
suction out real quick?
expedited this. Didn't even have time to say goodbye. So I try to as much as I can, which brings me to the Trendelenburg position. What is the contraindication to a Trendelenburg position?
Cranial pressure.
Which means if I have high blood pressure, how would you like to position me?
The other way.
Right? So that it doesn't go to the brain. Which means if I have low blood pressure, how would you like to position me? Why?
Because you'll get more blood flow.
Because now I want to perfuse the brain. Which is why when I go to the unit and I see my patient that way, I'm saying it's going to be a long night or a long shift. Okay? So after the extubation process, you've shown them, right? After the extubation process, this is just me. I know Mr. Sousa encourages coughing and deep breathing and use of suction or yonker. What else can I adjust and suggest to my patient?
Yes.
Yes.
Is the least expensive piece of equipment to tell you guys to take a deep breath. And if you can teach them that and revisit them as you pass by, it's really, really going to help your patients a whole lot. Any other question? Come on, you guys, I gave you an early. Don't